Today's lecture is on the principles of healing. Our course objectives for this lecture are explain the differences between primary and secondary healing. We're going to identify the three phases of healing and key components of each. We will describe the focus of treatment for each phase of healing. We'll differentiate healing times and optimal stimulus for healing different types of tissue. We'll explain tensile strength for tissue and its importance for return to play. And we will describe the factors that influence healing. Injury is a simple equation. When your demands exceed your capacity, injury occurs. So you may be a 300-pound lineman and have a 100-pound person fall into the side of your knee, and you have no results of injury. Or you could be a 100-pound person and have a 300-pound lineman fall into your knee, and the results will be a tear of the MCL. So we can have injuries that are from mild to severe. We may have minor disruptions such as a grade 1, a moderate disruption as a grade 2, or a grade 3, a complete disruption. So we have primary and secondary healing. Primary intention is the first, secondary intention is the other. Primary occurs when separation of tissue is small. The cells are able to bridge together that bind the ends, and these are minor injuries, so they'll heal well without any type of intervention, be it sutures or any type of surgical intervention. So we think of this like a small cut you may have on your hand that will heal without any problems, or maybe a minor grade 1 MCL tear where the fibers of the MCL are still together and will bind down and once again become nice and stable for that knee. We also have secondary intention, which occurs with larger separation of injured tissue. With this, the cells fill in from the bottom and from the sides to bridge the gap. Of course, these are going to take longer and have results of more scar tissue that are going to occur. So these are more of your major injuries. On these, we may think of a defect that we have in a muscle with a muscle strain, such as a hamstring strain or a quad strain, where these are going to take a lot longer, or you have a larger injury to the skin, maybe a larger abrasion in which layers of the skin are removed and they have to heal from the inside out, or something maybe along the lines of an infection that heals from the inside out. So we have three phases of healing. The first is the inflammatory phase, then the proliferation phase. It's also known as the fibroblastic phase. Then we have the remodeling or the maturation phase. So for the purposes of this course and for testing, if you will know the proliferation phase and the remodeling phase, we will stay with those terms. So I will not interchange fibroblastic with proliferation or maturation and remodeling phases. First, the inflammatory phase typically begins within 6 to 8 hours and lasts from 48 to 72 hours. This is really an important and necessary step in the healing process. So it has three parts to it. The injured side is first contained. So we have vasoconstriction followed by vasodilation. It is then stabilized by the formation of a fibrin plug. And then we have the phagocytes remove debris. The primary goal of the clinician is to minimize the inflammatory response, as it is deleterious when it is prolonged. So we're trying to make sure that we're not doing things to make this inflammatory phase be prolonged. We want it to do its job. We want the body to contain, stabilize, and then remove debris and move forward so that you can go to the next phase of healing. We have signs of inflammation that include redness, edema, pain, heat, and loss of function. You may also want to be familiar with the Latin terms for these as rubor, tumor, dolor, calor, and functio lassa. So we have redness, or rubor, which is results from increased blood flow, increased metabolic rate, and histamine release. And we also have edema, which results from leakage of fluids and cells and chemicals. Then we have pain that can be a result of the mechanical pressure or chemical irritation of nerves, or it can be both. So you can have excess edema in a joint, which then puts pressure on a nerve, which causes pain, or you can have some chemical mediators that are released during inflammation that are irritating to the nerves. And then we have heat, which is also an increase in blood flow, increase in metabolic rate. So the heat and the redness kind of go together. Anytime you think of something that's hot, it typically becomes red as well. And then probably most importantly for us as athletic trainers, we have a loss of function. And the loss of function can be a result of muscle guarding or tissue damage or just pain inhibition. The next phase, the proliferation phase, once the removal of debris is accomplished in the inflammatory phase, then the proliferation phase begins. It's thought to last 2 to 4 weeks, generally takes 5 to 21 days. So the fibroblasts are cells that are responsible for new growth and is marked by angiogenesis and formation of granulation tissue. Angiogenesis is the growth of new blood vessels, which is important for the formation of scar tissue. So the picture here is granulation tissue. It is a combination of extracellular matrix and a newly formed capillary buds. You'll notice the bright beefy red appearance. This is a result of the capillary growth. And if you will look down into this, the center of it, you'll see little circles there, and that's the new cells that grow forth. That's the granulation tissue, and it pushes out from the center, from the inside, and grows to the outside, and these cells fill in, and your skin will be restored back to normal once again. So collagen is produced by fibroblasts. It provides a structure to the wound and it replaces the fibrin plug. It may begin as early as 2 to 3 days after an injury. It begins with type 3 collagen, and it is marked as being weak and thin. And this collagen is laid down in a haphazard manner, which doesn't allow for much movement, but it does allow for tensile strength at the site of injury. And then as the type 3 collagen is replaced by stronger, more durable type 1 collagen, the injured site becomes even more, has greater tensile strength. And so at about day 12, the type 1 begins to really replace the type 3. And the remodeling phase, this is a long-term process, generally may take 12 months. It can be anywhere from 6 to 18. So it's marked by the maturation of collagen structure and arrangement. The wound tissue converts to scar tissue. Type 1 collagen is synthesized and type 3 collagen is destroyed, increasing the strength of the tissue by collagen fibers becoming organized in a parallel fashion. Remember, I just said in the previous slide that the type 3 collagen is laid down in a haphazard fashion. So as it matures, it becomes more laid down more into a parallel fashion, and that's what allows for movement to occur without any restriction from the wound. So rehabilitation in the healing process, the number one goal in any of these phases is never to overstress healing tissue. So realize as the healing tissue progresses through each of these phases, it will become stronger and stronger. And so things that you may be able to do in the last phase of rehabilitation would overstress the healing tissue in the inflammatory phase. So really the inflammatory phase we want to think of as the protection phase. We want to protect that tissue from becoming overstressed. We want to allow the inflammatory process to occur, and we want to move on from that inflammatory phase as quickly as we can. So our objectives in the inflammatory phase are to protect the site from further injury. We want to control pain. We want to limit edema, and we want to promote normal healing. Then our objectives in the proliferation phase, which is a return to function phase. So now these people are able to do a little bit more. They're less restrictive, less painful. And so at this point, we still want to promote normal healing. We want to restore range of motion or flexibility. We want to improve muscle strength and endurance. We want to improve proprioception, balance, and coordination. We try to return them to normal function during this time, and we want to minimize their deconditioning. So during the inflammatory phase, we're just trying to hold down the inflammation. We won't want to stir it up too much and let the body do its normal thing to stabilize and then to remove the damaged tissue and remove the debris. But now that we're in the proliferation phase, we start working more aggressively into regaining the range of motion. We want to minimize any type of atrophy that may occur with the muscles, so we want to start working on strengthening and getting the muscles to fire and work. We're able to begin proprioceptive exercises, and the real key is we want them to function normally. So we want them to walk normal, we want them to be able to dress, we want them to be able to get around campus, go to class, but they're not yet ready to begin sport participation. That begins at the remodeling phase, which is the return to play phase. So we want to return them to full strength and power. We want to regain their conditioning, and we want to develop a set of sport-specific skills that will allow them to return to practice and full participation. We also want to protect them at this time from preventing further injury. So we want to make sure that we're modifying any of our sport-specific exercises or activity to make sure that they are not putting themselves at further risk for re-injury. So if we have an ACL or maybe we have a meniscus repair, we don't want to do a lot of twisting and cutting at the very early part of the remodeling phase. We'll save that for later on once they've mastered some more of the straight line skills. So all tissue is not created equal. All will follow the same steps of healing, but tissues vary, and so do the events specific to the tissue. So a tendon, it has specific structural items that the other tissues do not. It has a synovial tissue or synovial sheath. It has an epitendon, an endotendon, which provide vascular supply to the tendon. And then the muscle has satellite cells, which restore and replace muscle cells as they're damaged by activity. So we think of these satellite cells definitely becoming active whenever you have DOMS or delayed onset of muscle soreness, where they are actively restoring the muscle to its pre-injured state. We have articular cartilage as type 2 cartilage, and it's also known as hyaline cartilage. It has it's avascular and aneural, so it has a poor metabolic rate and it's going to heal much slower than any of the others. And then we have bone. And bone is marked by having osteoblasts, which are bone generating cells that are specific to bone and not other tissues. So we look at these four different, I guess we got five there. We got ligament, tendon, muscle, articular cartilage, and we have bone. So let's look at how ligament will progress through the three phases of here. So the ligament begins the inflammatory phase in the first few hours, moves on to the proliferation phase in the first couple of weeks, and then the remodeling phase may take quite a while here. 6 weeks to 12 months, about 40 to 50 weeks, it is back to more normal tensile strength. Whereas the tendon, it too starts early, 1 to 3 days, takes 10 to 35 days for collagen synthesis to occur, and then at 2 months the collagen is mature, and at 40 to 50 weeks it is 85 to 90% strong. And then muscle, the inflammatory phase begins at about 6 hours. 7 to 11 days, the tensile strength is near normal. So we see a big shift between muscle and tendon. And remember that muscle is attached to a bone through the tendon, so it's kind of hard to, we have to realize if we're working muscle or if our purpose is to work a tendon wherever we're doing specific exercises. So the muscle is going to go through the proliferation phase much quicker, and then by 6 months it should be 90% of normal, although a smaller minor injury may be more like 6 weeks. So articular cartilage is a little bit slower on the uptake as far as moving into the inflammatory response. So you may not see an inflammatory response until a day or so after the event of damaging the articular cartilage or irritating the articular cartilage. The proliferation phase may last up to a month, and the remodeling phase can last 2 to 6 months. The thing that we have to remember with the articular cartilage is that slow metabolic rate. That is just going to move much slower. We can't get nearly as aggressive as articular cartilage as we can with muscle or even ligament. And then the bone, the inflammatory response begins immediately. It lasts about 4 weeks into the proliferation phase. And at 12 weeks, bone is near normal strength, and it's one of the few that it's going to go back to 100% tensile strength. It is really the only tissue that has that capacity. So whenever we're trying to influence healing tissue, we got to remember which type of tissue it is. Is it a ligament, a tendon, a muscle, cartilage, or bone? And we want to adjust our exercises as far as our repetitions, our weight, the intensity and frequency that we're doing the exercises. So ligament, we need pretty high repetitions, but we need low weight. We don't want to load that ligament up because remember it's one of our primary stabilizers for a joint. So we don't want to overload that joint and potentially damage that ligament or cause even more damage to a joint because we overloaded the weight on this. So we want controlled and protected movement. So we're probably working more in a single plane of motion rather than multiplanar activities to begin with here. And then our tendon, we want high reps, low weight. We do cross-friction massage or scar massage and tendon gliding if we have a post-operative tendon repair. We want to orient that scar tissue in the lines of the tendon's axis. So a muscle, we want fairly low reps and sets, but we want to increase our weight on those. And then our articular cartilage, we want very high reps, real high frequency, but low intensity. So we're looking at doing 1,000+ repetitions a day. And then we also want intermittent compression due to fluid phase acceptance. And then bone, we immobilize and protect. So Wolff's Law is a law according to which biological systems such as hard and soft tissues become distorted in direction correlation to the amount of stress imposed upon them. So basically what Wolff's Law does is it says that soft tissue is going to heal in the lines of stress with mobility. So we're going to move soft tissue, whereas hard tissue heals in the line of, so again, hard tissue, we're thinking of bone, moves in the line of immobilization. So lines of stress with immobilization. So that's the reason we used to put them in casts and leave them in casts for 4 to 6 weeks. Now most of our casts are not the hard plaster and they're removable, such as a walking boot or a brace or splint that we can immobilize a bone. And again, that's with the closed reduction. An open reduction, we stabilize the bone through hardware such as a rod or a pin or a screw. And so that would be our open reduction. Let's talk about tensile strength, which is the maximum amount of force or stress that a structure is able to withstand before the tissue of failure occurs. This tensile strength rarely returns to pre-injury level, may take up to a year to reach near normal levels, and the strength of tissue surrounding the injury allows the athlete to return sooner. So an athlete that has, let's say they injured their knee, let's say in grade 2 MCL sprain, someone that has rather large quadriceps and well-developed quadriceps and hamstrings is going to be able to return much quicker because of the strength of the stability of the muscle around the joint compared to somebody that maybe has poorly developed muscles in their legs. So during the inflammatory phase, the tensile strength may drop as low as 50%. At this point, it's relying on that fibrin clot, but after about 5 days, it begins to increase. Also, this is dependent on structure. It's very variable, And like I mentioned a minute ago, that bone is the only one that will return to 100% tensile strength. At about 12 weeks, it's going to be at 83%. Usually at about 6 to 8 weeks, an athlete will be able to, assuming there's good healing that's taking place, they'll start being able to put stress across that break and return to some light activity. So some factors that impede the healing process. So surgical repair, post-operative management, we have to take those much slower than if somebody doesn't have a surgery because of all the collateral damage that occurs. Age is a major factor. Younger folks heal much faster than older folks. Secondary disease. So if somebody has type 2 diabetes, will slow down their healing process quite quickly. If they have a secondary infection, so if somebody has a knee surgery and that knee becomes infected, then that's going to slow their healing down considerably. The size of the wound, that one seems like a no-brainer. The bigger the wound, the longer it's going to heal. The smaller the wound, the quicker it's going to heal. Nutrition, we want to make sure that our athletes are getting plenty of protein in their diets that will allow for healing to occur. And you also always want to make sure, so like some of our young ladies who may be at risk for eating type of disorders, that we're mindful of that, and we have a strategy in place to address those type of things if we think that might occur, because that will definitely delay healing. If we have a young lady, say a track athlete, that has a stress fracture, very thin, let's talk about what they eat, how much protein they're getting in, talk about their diet, maybe even refer them to a nutritionist. And then edema, it will definitely slow things down, especially if you're thinking of your knee as any type of edema, especially a joint effusion, is going to slow the quadriceps muscle in returning to its function. That's our lecture this morning, and for now, and we will spend time in the lab doing other stuff. Hope you enjoyed it. Come to class prepared to answer questions and ask questions for anything you did not understand.